Hello and welcome everyone to the Global Summit online webinars. We like to call it the Olympics of Dentistry. Good morning to all of you in the USA and good evening to us here in the Middle East and Europe, and good afternoon to the rest of the world. Today I have the honor to host one of the eminent speakers and a dear friend, Dr. Mahmoud Ezzat Ghazi. Welcome, Dr. Mahmoud.
Thank you, Dr. Amr. Thank you.
All the way from Egypt, we'll start today to talk. Dr. Mahmoud will present a topic, an interesting topic about the digital treatment planning for implants in the aesthetic zone. Most of us are interested in this topic. And let me read quickly the biography of Dr. Mahmoud before starting our lecture. Dr. Mahmoud Ezzat received his BDS degree from the Faculty of Dental Medicine at Ain Shams University in Cairo, Egypt, 2002. He then attended a program by the Royal College of Surgeons, Edinburgh, and received the membership degree in general dental surgery. 2011, he was appointed deputy in the MRD course director at Future University in Egypt, for the postgraduate specialty program. In 2013, Dr. Mahmoud attained a fellowship degree in laser dentistry from the University of Genova in Italy, and he has lecturing on the subject ever since then. Now, after some time in 2018, Dr. Mahmoud was elected as the president of the Digital Dentistry Society Arab Union sector in the Middle East, and in 2019 he was elected as a board member in DDS Global Digital Dentistry Society. Dr. Mahmoud is also a certified DSD instructor, and last year he was awarded the DSD Instructor of the Year. Also, Dr. Mahmoud is an international speaker and a key opinion leader and an international reviewer. Lots of titles, Dr. Mahmoud, and many more. I summarized what I could. So we welcome you, and let's start our lecture.
Right. Thank you so much, Dr. Amr, for the introduction. And thank you for giving me the opportunity for being for giving this 1 hour lecture with you all, or for you all, in this beautiful platform. Dr. Amr is a very close friend, and we have been working together for some years now, joining our minds in digital dentistry. Any new idea I always have, he's the first person I always come to, where we brainstorm it through, try to brainstorm through it and try to get a solution. And he always has these out-of-box solutions for everything that involves digital. So thank you for that. It's a great honor for him to be hosting this webinar today. Thank you all, of course, for your time. I don't know, can you all see my presentation now, or yes? Perfect. So I'll be going through screens that you can all have a look at the presentation. As Dr. Amr said, my name is Mahmoud Ezzat. I'm based in Egypt. I'm a board member of Digital Dentistry Society, president of Digital Dentistry Society Arab Union. I'm also a certified DSD instructor. And mainly what I always love teaching or giving more knowledge about is treatment planning. Because to me, treatment planning is the basis of dentistry. It's what dentistry is all about. If you can really plan out the case from the beginning to the end and really know what you need to get out of this case, without having a lot of guesswork in the middle, without having to stop in the middle and change your plan because everything didn't go the way you were expecting. Treatment planning also involves meeting your expectations with the patient's expectations and with your lab. It involves mostly the whole brainstorming process before you even start with the patient, so that you can give your patient a more predictable result at the end, because this is what our patients want from us at the end. They want us to plan out their cases, take all the information needed, and deliver for them something that will live for a longer time, something that would look good, something that would function very well, and something that would be biologically, of course, acceptable and pleasing. So I've been teaching treatment planning for most of my years, past 15 years, during the teaching process or the different teaching platforms that I was introduced to. And ever since I went into digital, it has changed my workflow totally. Because when I went into digital dentistry, this is where the main advantage comes into me in dentistry is visualization. With digital dentistry, just imagine instead of having your patient in front of you on the chair, you actually have your patient on your laptop or on your computer screen in all layers that you can imagine, having the CBCT looking at the bone and the teeth and the roots, having the intraoral scan where you can see the gums and the crowns, and having, let's say, a photo or a facial scan of the patient where you can see the face and you can see the skin. So you can see your patient in layers, and you can take as much time as you want with that patient to see everything that you need in 3D and start to really treatment plan this case correctly, and then give a virtual final result for yourself and start to see how you would reach that. One of the other advantages of digital dentistry is you have the end in mind, meaning that you can plan everything ahead, you can see the end in mind, and then plan back, which we call reverse engineering, to get from the starting point to the end point. So a quick overview about digital dentistry. It's where you transform your patient from a physical patient, instead of the patient sitting there in front of you, to a virtual patient. And it involves three main steps, where we capture first, we take all our diagnostics, and we take our diagnostics, usually it involves three main aspects: taking photos or facial scans of your patient, where you have an overview of the patient's face. And of course, we all now understand that how important this is, where you can give an aesthetic proposal for your patient, or it would be impossible to give an aesthetic proposal for your patient without the face in mind. It's exactly like painting, where you're doing a painting and you've drawn something very nice, but it doesn't look good with the background around it. So the teeth are also always part of the lips, they're part of the cheeks, they're part of the face. So the face has to be there so that you can plan correctly where the teeth should be according to the face, what we call a facial driven treatment plan. And we do this using digital smile design. I'll give a quick overview about this. So we use cameras where we take photos of our patients, and we do our smile design accordingly. We use intraoral scanners or lab scanners where we scan our models, or we scan our patients intraorally, where we can see the teeth and the gums. Now we have a 3D overview of the teeth and the gums. And then we do our CBCTs, where we now have an overview of the bone and the roots. So there's no information missing there. You have the face, you have the teeth, the gums, and you have the bone and the roots. All the information needed is all in one place, and this is where we capture all the information. The second step in digital dentistry is where we start to process all this information. All this information is brought into your laptop, and we register them on top of each other, meaning that the face is in one position, and then the teeth and the gums are in the same position as they are on the face. And then we bring the CBCT in that same position again, and we call this registration. And this is where we can see everything in 3D in layers. And then we start to design where we want to place our implants, let's say, or where we want to do our wax up according to the patient's face. And we'll take an overview. This is where we process all the information we have so that we can give the final result to our patient. And then at the end, we manufacture our products, where we mill or we print or we center guides that help us to use this in the patient's mouth according to the plan that we have done. So this was a quick overview about digital dentistry. And from there, as we can see here, this is where we have our virtual patient. Now, if you look at on the right, this is where you have your patient's face, you have the patient's CBCT, you have the intraoral scan, and you can also bring in a wax up or virtual wax up in there, and you have everything registered, and you can see everything in layers so that you can totally treatment plan your case. You have the full visualization of the case, and you can go on from there to give the patient what the patient expected. Now, mostly when we come and talk about implant prosthetics, especially in the aesthetic zone, what we started with in the beginning, and we all did this later in a long time ago, is we used to plan for implants according to bone availability. And this was the most logic way of planning for implants at that time. And this is the capabilities that we had at that time. And then we started to understand that no, we need to plan for this prosthetically also. We need to put the prosthetics in mind, because placing the implant where most bone is dense, or where we have the biggest volume of bone, is great for the implant, yes. But at the end, the prosthetics will either turn out to look very bad, or it would be impossible to restore for the patient, or you would have detrimental, of course, functional loads on that prosthetics or on these prostheses, which could cause failure for your implants later on. So we started to understand that we need to have a prosthetic-driven or restorative-driven treatment plan, where we need to plan where our tooth is going to be first according to function. Mostly at that time was according to function. And then accordingly, we would have a virtual crown there, or a wax-up that was done, a manual wax-up. And then we would plan where the implant would be in the most suitable position to the prosthesis. And then later on, we started to find that functionally this would be great, biologically this would be excellent, but that didn't mean that it would look good aesthetically for the patient, because this is one of the most important things why our patients are restoring teeth. At the end, what they really understand is how this restoration is going to look at the end. Does it look good or not? Because most patients are always looking for social acceptance. So then we start to understand that we have to also put in an aesthetic proposal, meaning that's not just according to the function and the biology of the crown or the restoration that we're doing. We also need to put aesthetics in there, in mind. And to put aesthetics in mind, we need to take an overview of the face. We need to plan where these teeth should be according to the patient's face, because these teeth have to look good and blend in with the patient's face at the end. And this is where we started to bring the smile design in the process first. So we started the smile design, do the smile design, and then according to the smile design, do a digital wax-up. According to that digital wax-up, plan where the implants should be placed and their positions and the numbers. And then I started to think even at a further step, or a little differently, because each case differs from the other, meaning that placing an implant would differ according to the type of prosthesis that this patient, you'll be able to deliver for this patient. Is it going to be an FP1 prosthesis, meaning that the implant should be placed in exactly the same position where the root should be, as this case, let's say? If you have a look at this case, at the before picture, you can see that the patient, this was a failed bridge. The patient needed, some of the teeth needed to be extracted and implants placed. And we also planned for placing the implants in the missing spaces. You can see that she has deficiencies in the papillas, but in this situation, you can regenerate these papillas once more. So accordingly, you would place the implant at the level of the patient's root, okay, which is usually 3 to 4 millimeters from the zenith point in depth from the proposed crown. So here it would be possible to regenerate the papilla once more. So you treat the implant as if it is going to replace, or exactly, if you can, in the same position that the root was there before it was extracted or just after extraction. So this is if you're going to use an FP1 prosthesis. But what if you have a case like this? Now look at the picture, the before picture. This patient has a large deficiency in bone and soft tissue. He had a bridge replaced on implants in this case. And look at the deficiency he has, not only in the papilla levels, but also in his gingival margins. Now, the only solution for this patient, it would be, of course, impossible for you to regenerate these papillas either, or the soft tissue, either surgically or prosthetically. So now you have to think of a different way. You have to do this. Let's say you need to use a hybrid prosthesis for this patient. You need to restore both gingiva and white and pink at the same time. And usually these type of cases where you have partially edentulous area, especially in the anterior region, it would be very difficult to replace the pink that you need with porcelain, because you do not have too many shades of pink porcelain. That's number one. And number two, the gingiva is in multicolors. It would be very difficult for you to register the shade for this patient, send this to your lab technician, and your lab technician would be able to adjust this. So what we do here with these type of prostheses is we add on the pink porcelain, we have a thin layer of pink porcelain for the prosthesis, and we add on this pink composite. So to be able to do this, you need to do part of this intraorally. But other than that, this implant needs to be placed above the patient's upper lip level, because the most area that is visible when you do a pink or a hybrid prosthesis here is the demarcation between the prosthesis and the soft tissue. So you need to bring everything to a higher level. Here, everything is already at a higher level. So given that the bone is above the patient's lip level, this is an advantage here in this case. Well, what if you could not again restore the gingiva in this case, but the bone level was beneath the patient's upper level? Then you would need to equalize the bone and bring it to a higher level so that you can hide where the implants should be. So the whole idea here is, because I cannot restore the papillas or the soft tissue either surgically or bring them in prosthetically, I need to bring in something artificial. So my implant position would be totally different. Here, it is above the upper lip level. Another case, and most of the cases that we are all familiar with, was a fully edentulous case. Now here you need to think about distribution. You need to put in mind that the implant angulations need to be very close to each other, so that, because you will have a lot of problems in the prosthetic phase. And here, the difficulties here are usually in the prosthetic phase more than the surgical phase. So depending on the point I want to make is, depending on the case, we do not only put in mind function, we do not only put in mind aesthetics, where the upper lip is, the deficiencies we have in the papilla levels, the deficiency we have in the gingival levels. We also have to put in mind, the type of prosthesis I'm going to be able to use at the end. Is it going to be an FP1 prosthesis? Is it going to be an FP3? This will change totally how or where the number of implants I'm going to use, my distribution, the angulation of the implants that I can use for the case, the positions of the implants, the type of implant I'm going to use, the type of abutments I'm going to use. Are they going to be a multi-unit abutments? Are they going to be non-engaging abutments? Are they going to be on tie basis? So what I'm going to show you through the cases that we're going to go through is the sequence that I use that works with me and works with my patients, or the workflow that I use. And you'll find that only at the end do I start to plan for my implants. So I start to plan aesthetically first, and then I start to bring in biology and function as part of my treatment plan. And then only then do I bring in my implant planning and start to plan for my implants according to the prosthesis I'm going to use. So I'm going to start to show you the first case, and then we'll go and you will understand more what I mean through the workflow that we use. So the first step that I do when any patient comes in is I start to take facial photos so that I can do smile design. And as I said, the main objective of using facial photos is that we can design the aesthetics of the case according to the face. And as we said, the teeth are part of the lips, cheeks, and face, so the face has to be there. So one main photo that we need to use is a frontal smile photo, so where the patient's eyes are open and the patient is at full smile, so that we can start using the patient's face to do the smile design. These are the intraoral scans of the patient, the intraoral photos. You can see, of course, the papilla deficiencies that we have, the case, the unequal papilla tips and gingival margins, and how challenging the case was. So quickly, an overview about the smile design and its relevance and how this can be done. The first thing we do is we take a facial frontal photo. We bring in a horizontal line and adjust that photo to our horizontal line so that we can adjust our prosthetics accordingly. We then bring in a vertical line which shows where the facial midline of the patient is and where the dental midline should be accordingly. You'll find on the top of the screens the references that we use for each aesthetic principle. I'm not going to go into details about smile design because this is not our topic today. We then brought in our smile curve. We started to measure where the lower facial height is, and we started to divide our lower facial height into 3/3, which will show us where the new incisal edge of the centrals should be. We also took a photo of the patient at rest, and we found that her centrals were a bit too long. Usually at a middle-aged woman should show about 3 to 4 millimeters at rest. So accordingly, we started to plan that maybe the incisal edges are a bit too long on her face. We need to make them just a little shorter. Accordingly, we decided where our new smile curve is, and what the smile curve shows is where the incisal edges of all the teeth should be while the patient is smiling. Then we started to bring in an interdental ruler, which divides for us where each and every width of the centrals and the laterals and the canines proportionally to each other, where they should be, and where the canine eminence should be according to the inner canthus of the eye. I'm sorry that I'm going through this very quickly because this is a totally different topic, not something that we can go through in less than 2 hours or 1 hour at least, so that you can understand. I'm just showing you how the plan was done for the case and how we use the face. So now I know the width of each tooth, the width of the center, the width of the lateral, and the width of the canine, proportionate to each other and proportionate to the face. Then we decided where the height to width ratio of the central should be, meaning where the incisal edge of the central should be. This was according to the smile curve. I now have information where the mesial and distal of the central is. And now I'm starting to decide where the gingival margin of the new central should be, according to the 80% ratio. From there, I now know where my gingival curve is, meaning where the zenith points of all the teeth are going to be. And then I start to decide where the papilla curve is. And one of the most important thing in implant prosthetic treatment planning is where the papilla curve should be. And this papilla curve shows you where the papilla tips of each tooth should be, and if you have deficiency there or not. So if we take a closer look at the case, so that you can understand more, if this red rigid line is where the patient's gingival margins and papilla tips are, you can see that the papilla tips are totally deficient. There are actually no large deficiency in the papilla tips. They're very close to the gingival margin. And if you look at the smile design that we have done, this is our new gingival margin now, and this is where our new papilla tips should be. Now, what I have done, if you think of it as an overview, is I have, remember I told you that we're going to make the incisal edges just a little shorter, and I've brought the gingival margins to a higher level. So I've brought the whole case from a lower level to a higher level so that it's more favorable for me prosthetically and much easier and more pleasing for the patient aesthetically, and much easier for me to regenerate this papilla either surgically or prosthetically. So that's the whole point I've done. Instead of having everything at a lower level, I brought everything to a higher level because she has large deficiency in papillas, and giving more space between the gingival curve or the gingival zenith and my new papilla tips, so that it'd be much easier for me to regenerate this or to give a better or a more aesthetically pleasing look for the patient. Now, what is my limit? My limit is two things. Actually, the biggest limit is the patient's upper lip, because if I go to a much higher level, then I'm going to hide everything behind the patient's upper lip, and I haven't benefited anything from what, or I haven't given her the maximal smile that she had been wishing for, right? Then I would make everything shorter. So my limit is actually the patient's upper lip while the patient is smiling. So when you think of it, it's very easy to think of as a treatment plan, but when you don't have the face there, it's very difficult for you to imagine, is this the correct level? Is this the correct position? Is this going to look good on the patient or not? But because I have the face there, I can very easily plan for this, and I can know that this would look perfect on my patient. And of course, at the end, I'm putting in mind biology and I'm putting in mind function, and these are the next steps that we're talking about. So what I've done now is I've done an aesthetic proposal for my patient. I understand now what I can do, what I can give my patient, but this will never be complete unless I have also the biological and the functional perspective in mind. And this is where the next steps come in. So according to the smile design or the aesthetic proposal or the aesthetic plan, I now bring in, because the next step is bringing in my intraoral scans and doing a digital wax up according to the smile design that I have done. So according to these lines that I have drawn, I'm now going to bring in my intraoral scan, and my intraoral scan, of course, shows me the gingiva or the soft tissue and shows me the crowns or my teeth, so that I can plan accordingly and do a digital wax up according to that smile design. So these lines that I have here are called the smile design. I don't need the face anymore because these lines translate what I got as information from the patient's face. I now know, and you can see here in the photo in the middle, where my new gingival margin is or zenith is going to be, where my new papillas are going to be, okay, and where my new incisal edges are going to be. So this is what I was talking about. I brought my smile frame over to a higher level, and I know that this higher level is favorable because this is the level of the patient's upper lip while the patient is smiling. So what I'm going to have is just her papilla tips showing while she's smiling in maximum, and I know that when I make them shorter, they're still going to look good because I have them at the level of the lower lip while the patient is smiling. Okay, so from these lines, I bring in my digital wax up, or I choose the shapes that I'm going to use for this patient, and we use natural tooth shapes so that they can look, we can give our patient a natural smile. And according to these lines, I now bring in my wax up, and I now can start to visualize in 3D where each tooth is going to be according to that aesthetic proposal. And this is where I start to bring in my functional treatment plan with the lower teeth so that I can understand more and start to adjust this wax up according also to function and occlusion. Now, the aesthetic proposal was bought in from the face. Accordingly, the teeth were bought in or designed according to that aesthetic proposal and according to patient's face. Now I'm adjusting my digital wax up also according to function and occlusion to make sure that this is possible and that this will function correctly with my and live for a long term for my patients. After that, we started to treatment plan where the crowns are going to be, where our implants are going to be, what we need to reshape. And we started to decide that we needed gingival reshaping here at the centrals because I'm bringing the gingival levels to a higher level. So I'm going to need either gingivectomies or crown lengthening. I cannot decide right now because I do not have the CBCT in right now. But when I bring in the CBCT, I will be able to see the new bone levels and if I need to go for just a gingivectomy or I need to go for osseous crown lengthening at the centrals or not. You can see that the two laterals are now in a more favorable state as the gingival zeniths are just lower or at a lower level than the centrals. You can see that this canine now is in the perfect position, my new gingival margin. You can see the gingival margin here is just a little short at the right canine. So I'm going to need, again, gingival reshaping. I started to decide that these two laterals or the teeth are in green are the teeth that are going to need implant supported crowns. We were going to go for bridges at the posterior areas because the spaces here were too deficient mesiodistally. So it was quite impossible to place implants. So we're going for a fixed bridge. Which teeth are unrestorable, which teeth were restorable, all of that will come in the next part. So the next part is looking at the CBCT or the patient's bone and starting at the end our implant planning. So step number one, as we said before, bringing in the face, the aesthetic proposal. Step number two, bringing in the intraoral scan, doing the digital wax up according to the aesthetic proposal, adjusting function. Step number three is bringing in the CBCT, registering the CBCT on top of each other every time. So every time I bring in new information, it's not a new plan. It's a continuation of the plan. Why? The photo is brought in first. The intraoral scan is registered or aligned to that photo. And then when I bring in the intraoral scan, it's brought in that same position once more. So it's a completion of the plan. Then the CBCT is brought in that same position once more. So it's a completion of the plan at the end. So when we bring in the CBCT, it's registered to the plan that we have already, that we've done. It's registered to the intraoral scan and the digital wax up. And now what we have is our virtual patient. We can see our patient in 3D, as we said, and we can see all the information. This is where you have complete visualization of the case. And as we said, we needed soft tissue recontouring for the centrals and the canines. And I would never able to decide if this would be crown lengthening or just a gingivectomy or just a soft tissue surgery unless I had the CBCT here. So when we bring in the CBCT, usually in these type of cases, we have the patient hold the retractors or have cotton rolls in the labial vestibule while the patient is doing the CBCT so that we can see, or we have the upper lip not in our image, and we can see the soft tissue profile on the CBCT. So we can see the soft tissue profile, where the CAJ is, where our new bone level is. We can see also the crown to root ratio. When we do our osseous crown lengthening, because we need the crown lengthening in this area, would we have at least a 1-to-1 crown root ratio in this area? we can plan everything accordingly, and if this is going to be safe and more predictable for our patient at the end. So we can see where our CAJ levels are, so that we do not go beyond the CAJ levels, because once we go beyond the CAJ levels, then we would need to go for aggressive reduction, because we would be on the patient's roots, not on the CAJ or on the crowns. We can also see our crown to root ratio. We can also see the amount of soft tissue that needs to be removed and the amount of osseous reduction that would be needed. Okay. This is the most integral part. The next step is the most integral part for me. Is yes, I've planned for the aesthetic proposal, the mastication and the function. Now, what would differ for me, and what the main factor that would show me where my implant positions would be, is the type of prosthesis that I'm going to be able to use with this patient. And this is where I refer to the study done by Turnau, which shows the amount of soft tissue reconstruction that you can do near an implant, especially for deficient papillas, depending on the relation that you have. Meaning that if you have a tooth-to-tooth relationship, meaning a tooth near a tooth, and the proximity limitations, of course, the proximity of the roots is up to 1 millimeter, then you may regenerate up to 4.5 to 5 millimeters of the soft tissue. Meaning, let's say I have two centrals, as you can see in this photo, and I have a deficiency of the papilla in this area. And if I measure the distance from the interseptal bone to my contact area, and this area is less than 5 millimeters or within 5 millimeters, that means that it would be possible for me to regenerate this area either surgically or prosthetically. Surgically, this is a totally different topic, but what I'm going to talk to you about is how to do this prosthetically. So simply, if we place pressure on our papillas from the mesial and the distal of both, if I recontour those two centrals with, let's say, composite fillings, and I have a deficiency of the papilla, and I just place pressure on my papilla from the mesial and the distal, then my papilla would migrate down to that contact point or that deficiency that I have. So what is my limit if I have a tooth-to-tooth relation? It's 5 millimeters. That's my limit. What if I have a tooth-to-pontic relation? Then the limit is much less. I can regenerate up to 6.5 millimeters. So that's great. What if I have a pontic-to-pontic relation? It's 6 millimeters. What if it's a tooth-to-implant? It's less. It's 4.5. What if it's an implant-to-pontic? 5.5. What if it's an implant to implant? That's the least probability that I might be able to regenerate this once more, and that's 3.5 millimeters. So I have always that in mind. If I have two implants adjacent to each other, the probability of regenerating the papilla is much less than if I have an implant to pontic or a tooth-to-tooth relation. So this we always have to put in mind. And the only way, because like I said, the measurement that we're taking here is from the interseptal bone to the contact point. So how do I know where my future contact point is going to be? Where my future contact point is going to be, I can see from my digital wax. That's simple, okay? So how do I see where my interseptal bone is? Through the CBCT. So this is where all the information we have is relevant. So this is my intraoral scan. This is me measuring the deficiencies against the smile design that I had done. Why? The papilla curve shows me where my contact points are going to be. So now I know the amount of deficiencies that I have in each tooth. I can visualize that from my intraoral scan. You can see at the canine area, my deficiency is about 2 millimeters. Between the centrals and the laterals, my deficiency is about 1 millimeter. Between the lateral and canine on the left side is about 2. So I can see the amount of deficiencies I have. But when I bring in the intraoral scan, the CBCT, and the digital wax up, now I can see everything. I can see where my future contact point should be according to the smile design that I did, according to the patient's face. I can see where my interseptal bone is, and I can see the amount of deficiency I have. And so easily from there, just a second, because my battery is going to be dead. Just a second, please. Yep. Just need to Sorry about that. So going back to that, I can now see where my contact point is, where the CBCT is, and where the wax up is. So I can visualize everything. So if I go back to the study that we were talking about, we were talking that one of the best options would be implant to pontic relation or a tooth to tooth relation. So now I can relate where my implant can be placed, and if this relation is more favorable, will I be able to regenerate this the papillas, the deficiency in the papillas in this area or not? Am I going to be able to use an FP1 prosthesis or not? Here we decided to use an FP1 prosthesis. So mostly our implant is going to be placed from 3 to 4 millimeters from our new zenith point or our new gingival margin of each tooth. And this is if we're going to use an FP1. But what if through these measurements we found that we could only use a hybrid prosthesis? We need a prosthesis to be used with pink porcelain or pink composite. We think in a totally different way. The implant needs to be placed at a higher level. It needs to, so that the demarcation between the prosthesis and or the pink and the patient's gingiva that's already there is hidden beneath the patient's upper lip. So the implant will be placed at a higher level. The distribution of the implants would be totally different because we would go for a hybrid prosthesis. We needed to think more about hygiene and how this patient would perform hygiene around these implants. In these situations, we usually decrease the number of implants. We usually cantilever also in a case, the next case that we're going to show, so that the patient can bring in super floss and do hygiene prosthesis as well. So this is the integral part where I decide according to if I'm going to be able to regenerate the papilla or not. I'm going to use an FP1 prosthesis, so my implant positions are going to be in such a way, or am I going to go for a hybrid prosthesis, so my implant positions are going to be totally different. So here we decided that we were going to go for an FP1 prosthesis. Of course, this would have been impossible for us to pre-plan unless we had all this information on one platform. We were able to get from the aesthetic proposal, from the smile design, from the patient's face, the aesthetic proposal. From there, the digital wax up and adjust this digital wax up functionally, then bring in the CBCT and start to visualize the soft tissue deficiencies that we have and where the bone and interceptal bone is. We then referred to the studies where if we would be able to regenerate this prosthetically or not. Then we decided we're going to go for an FP1 prosthesis. Accordingly, next step is the implant planning and our implant positions according to the decision that we were going to go for an FP1 prosthesis. So again, here, everything is already aligned and registered to each other. The digital workshop that translates the smile design, the intraoral scan, as you can see here, the CBCT, and now what we're putting in mind is planning for those implant positions to give or deliver for my patient an FP1 prosthesis. Then we started to do the smaller things or the smaller adjustments that matter, seeking for screw retained restorations, because this is, of course, more favorable, as we all know. Am I going to be able to do this in the anterior and the posterior area both? We were able to do this in the posterior area, no problems. But in the anterior area, it was very difficult. So in the anterior areas, we went for a screw-retained abutment, over it a cemented crown, putting in mind that, of course, on the screw-retained abutment, we adjusted our finish lines of the abutments to be equigingival so that we do not have any excess cement ingress within the soft tissue. And of course, the abutment to implant level was about or interface was about 3 millimeters from our new zenith, so that we do not have any soft tissue or bone loss in the future. So this is where you start to really improvise and start to adjust according to each case and give the most benefit for each patient according to the case, of course. So here we started to plan for tooth 1-4, 1-2, 2-2, and 2-3, the exact positions of the implants. And from there, this is when we finished our total plan for the case. We have the aesthetic proposal, the biological principles in mind, function and occlusion in mind, also how this is going to look on our patient at the end. This is when we start to present this whole digital plan to our patient, and then we start also to decide on our sequence of execution. So the next steps are just the execution. All these plans were then, or these designs were then fabricated and manufactured either by 3D printing and milling. As we said before, we decided to go for osseous crown lengthening for the 2 centrals. So this was a guide that we designed so that we can get the exact zeniths according to the wax up that we had done from the beginning. So this is the guide in the patient's mouth. This is the gingivectomies, and then the elevation of the flap and removing the bone so that we have our new bone levels. Then our surgical guide, where we decided to place our implants exactly. We opened the flap and we placed our implants in positions. We did our bone augmentation and the whole surgical procedure, and then sutured everything up. As you can see, we had already built up the centrals and reduced them so that we can temporize the patient during the healing phase. Now, I didn't go for an immediate loading for these implants at that time because I already had natural teeth, and so it was easier and much safer to temporize on the natural teeth. But here is where it took more and more time, because as we said, that the main way, or the main procedure that I'm going to go through at this point, this patient has deficiency in papillas. I'm going to regenerate these papillas prosthetically by placing pressure mesially distally on each papilla so that it could ingress or it could migrate in that deficient area. The easiest way to do this is using your temporary restorations. So that's what we started to do. And you will be able to see the results by sequence. This was the day of the surgery. You already had the temporary restoration pre-milled, and we just relined it in the patient's mouth. It is the same design as the finals that the patient is going to get also. So this is something that you can use as an advantage to get the patient motivated with the final design already. Doesn't look perfect, of course, as the finals, but it is a better step there. You can see the deficiencies that we have on the day of the surgery. This is 4 weeks post-op. You can see the healing that we have around the temporaries, given that they're finely polished and retained in place. And you can see that we started to have some regeneration of the papillas in the areas by time. And this is the final position that we were able to give the patient. You can see the final restorations in place and the papilla regeneration that we got. And as we said, the plan that we had at the beginning, the gingival margins just beneath the upper lip while the patient is smiling. The only thing evident is the papillas, giving the patient the perfect smile curve so that it looks beautiful on the patient. And this is a video where you can see the sequence of the papilla regeneration that we got. You will see the papilla regenerations that we got around the implants. Of course, also the Pontic designs around the implants gave us the perfect architecture that we needed around our restoration. So this is mostly where most of the time, where it took most of our time, but we already had pre-planned everything. We already knew what we were expecting. So this was a phase that the patient was very patient with us. She was very happy with when we used to see her every 2 to 3 weeks, and we would scan her once more, and we would show her the differences between and the progress that she had gone through. Got her very motivated with oral hygiene, because these type of cases need meticulous oral hygiene and patient compliance, of course. And again, this is the final results that we were able to give the patient. This is the before and the after. As I said, our main objective was to bring everything to a higher level. The smile curve, the papilla curve, and the gingival curve, given that it was a favorable position for the patient's lip, and we were able to regenerate this area or regenerate the papillas prosthetically without needing to go for an FP3 or a hybrid prosthesis that never looks totally natural as the patient's natural gingiva, of course, and papillas. And facial photos of the patient before and after, and our end result at the end. As usual, of course, the first case usually takes a little more time. But let's go through the next case. This is the case that I showed you before, where the patient has a huge defect in soft tissue and bone in the anterior area, and it's only in the anterior area, and the patient has a gummy smile. These are one of the most difficult cases that you can manage. And of course, again, Here, digital treatment planning comes in, and the advantage of visualization gives you an overview what you can do for this case exactly. This patient had huge psychological problems because of his teeth. He was getting married in a few months, and he wanted a solution for the position that he was in right now. So his expectations were very high. He had visited many dentists that told him that there was no way that that they could give him natural looking restorations. As soon as I saw the case, I said the same. But I usually never give my patient final options or unless I have treatment plan the case to the full. Now you can see after we removed the bridge, the amount of defect that we had, a huge defect. So we started doing the smile design once more, according to the smile design, where my new gingival curve is going to be, where my new papilla curve is going to be. And from there, we could start to visualize where our deficiencies are. Sorry about that. Now you can see with the lines that we have huge deficiencies, of course, again, in the papilla. It's the crown was totally elongated to try to mask that defect, but of course, it was a terrible job. So from there, we first do a mock-up for our patient. This is very important. And we show our patient the end result. And when we show the end result, this is where we motivate the patient. This is a very important step. And it's an important step for us also so that we can visualize what we have given the patient as a plan and if it looks good or not, and if it needs to be changed at this moment or not. So this is the mock-up that we did for the patient before and after. The patient loved the aesthetic result. Of course, this is a mock-up that never looks like the finals, but he loved the way that he would look at the end. He loved the shapes that we chose for him. And from there, we started to visualize the plan. Now you can see from the plan here, the teeth, of course, were too long. This is our new gingival margin. The new gingival margin here needs to be above the patient's upper lip, because this is going to be because we're going to, of course, use a hybrid prosthesis in this area. It will be impossible to regenerate using the studies that we had showed you. So we are planning that the gingival margin has to be above the patient's upper lip, so that the demarcation between the pink porcelain or pink composite, or of course in this type of case a pink composite because it's partially edentulous case, needs to be below the level of the patient's upper lip and where the new papilla levels here. What's in white is where his future teeth are going to be, and what's in pink, of course, is where he is right now. So there's a big difference between both. And of course, we bring in the CBCT, the intraoral scan, and the patient's face so that we have the virtual patient once more. Again, referring to the studies, you can see that the deficiencies that we have are humongous. We have about 9 to 10 millimeters of deficiencies, an average of 7 to 9 between all the teeth. Of course, regenerating this prosthetically would be quite impossible. And we got these measurements from the CBCT. You can see the bone architecture here, how it's flat, and we have no interceptal bone between the teeth, of course, due to deficiencies that he already has or the bone that he has lost. And now, as you can see here also, I'm going back to the slide. From the smile design that we have done, we decided that we needed to do some gingivectomies or crown lengthening in the premolar areas. So this is part of our plan once more. The CBCT was used. We fabricated the guide. From the guide, we started to decide for our crown lengthening and the gingivectomies that are going to be done at the premolar areas. And we started to bring in our wax up. And if you look here at the soft tissue and the bone architecture regarding the wax up, this is what's in pink is the intraoral scan. What's in white is my digital wax up, where the teeth are going to be in the future. You can see that we do not only have a vertical defect, we also have horizontal defect. So we also needed to augment the bone horizontally so that when we bring in our hybrid prosthesis, or we place our hybrid prosthesis, it is against a flat surface so that it's much easier to do hygiene and it's in a more biologically acceptable position. So we also needed not only to regenerate, or we didn't only have a deficiency, in vertical bone, we also had a horizontal bone defect. So we really needed to regenerate that area and to bring the bone at a higher level than the patient's upper lip. So it's totally different way of thinking. We brought the soft tissue and the bone at a higher level, meaning we reduced the bone vertically so that it's above the upper lip level, so that the demarcation of the prosthesis is not shown or is hidden beneath the patient's upper lip while the patient is smiling. And at the same time, we regenerated bone and soft tissue horizontally so that we could have a flat profile, so that our prosthesis could rest on that flat profile, and it would be much easier for hygiene and for biological principles. So it's a totally different way of thinking. And of course, the implant levels were placed at a higher level. He already had 2 implants placed, so this was another difficulty in the case. We were able to use one, and the second on exposure totally failed. This was a guide we used, sorry, for the horizontal bone regeneration, just to show us the level that we need to reach to so that we can have a more favorable position. This is the guide we use for the gingivectomies and the crown lengthening. This is the gingivectomy procedure. This is the exposure of the 2 implants that were already placed. We placed another, extra implant in position. And of course, with the bone regeneration and the soft tissue regeneration and closure of the flap, this was the guide to show us just the level that we needed to regenerate horizontally so that we can have a more favorable position. And this is the day of the surgery, the suturing. And we fabricated, of course, a temporary prosthesis for the patient so that we could train the gingiva, and we could, of course, the patient could not be left without temporization. Of course, the temporary was designed according to our final design for the patient. And you could see here, this is the total big difference between, you can see here on the left of my screen, this is the wax up and intraoral scan before, and this is the hybrid prosthesis and after we had regenerated the bone horizontally. This patient is till now is in temporary, and this is the results that we had reached for now. He's going to the permanent after these coming days because of COVID-19. Of course, we couldn't complete the case. The temporaries were looked good on him, and he went for his actually engagement. He postponed his wedding. We're going to go for the permanence, and then he's going to go for his wedding straight away. The whole point of the case was to show you how the planning was in a totally different perspective, and how the aesthetic proposal is the one that governs in the beginning, and then function comes in, and then biology is the, let's say, the decision maker of the type of prosthesis you're going to use, and accordingly then only you would plan for where your implant positions and the implant sizes, and of course implant distribution, implant type, the type of implant and the type of abutments that you would be able to use for the case. Just one last case very quickly, okay? Of course, would have loved to go into more detail with you all, but of course we don't have that much time for that, but maybe in another session. Fully edentulous cases, or let's say a case with hopeless teeth where you need to place full arch implants. This was a case where I didn't go for the surgery, but these are one of the difficulties that we are all going through with full arch cases. It's not that difficult, of course, to place the implants because you have a large area to place your implants. I prefer doing this guided because not to place the implants in the correct position surgically according to the bone, but it will differ in your prosthetic phase at the end, because the nightmare usually is in your prosthetic phase. So accordingly, this patient came in with the hopeless teeth. All the teeth were extracted. Surgery was not done by me. It was done by one of my colleagues, Dr. Haitham Maayirgi. I did the prosthetics with him later on. Implants were placed. Angulations were very good, were very impressive actually, which made the prosthetics much easier. And this is what I was talking about mostly, that we need parallelism as much as possible with full arch cases to make our prosthetics with passive fit and make our life easier at the end. Suturing, welding, so that he could temporize. The patient's old denture was temporized in pace and on multi-unit abutments and temporary copings. And then the patient came to me for the prosthetics. And one of the most difficulties that I usually have, even though I'm using an intraoral scanner, is full arch cases. And of course, everyone with full arch with intraoral scanners knows this, that the accuracy between implant positions, especially for full arch cases, is not that high. And when you have a full arch implant case, you usually need to go back to analog, meaning you need to take an analog impression. You need to do verification jigs. You need to verify once more with your lab, and then only can you scan your model if you want to complete the digital way with scan bodies on a stone cast. You can never use an intraoral scan so that you can have a passive fit for your full arch restorations. And of course, this is all by studies. But I was introduced to a new technology called the PIC camera, or PIC dental, which is a camera that can pick up your implant positions very accurately in a few seconds and give you excellent passive fits with the use of your intraoral scanner at the same time. So this is what we tried with this case. The patient came in with the multi-unit abutments. We removed the temporaries, and we started doing the smile design once more. According to the smile design, of course, we started to find defects in the old complete denture or temporary prosthesis that was put in the patient's mouth. We started to adjust everything to the patient's face. We started to choose the shapes needed for the case, and accordingly we did our digital wax. Now the next step was doing our scan using the PIC camera. This is the camera itself. And it picks up the implant positions at multi-unit level or at implant level, whichever you prefer. But of course, at abutment level is much easier using these flags. And what you're going to see next is a quick video of how the scan was done very quickly in a few seconds. This is the scanner in place.
Those for them, I will just change it like this.
Now, as you can see on the timer, in less than 15 seconds, the full scan of the 5 implants in positions, all in green here on the screen, were taken. And the scan was done by the CEO of PIC Dental, Adrian Hernandez. He was good enough to come along for the case, come especially from Madrid to Cairo, so that we were able to do the case together. And the case was, he stayed in Cairo with us for 2 days. We scanned and designed and milled the case the first day, and second day we tried it in the patients, the final restoration, and we screwed everything in, and everything was more than perfect. So the case was finished in less than 2 days. So this is the PIC scan. We registered this to our intraoral scan. We now have our implant positions in 3D. Accordingly, we bring in the digital wax up that we had already done. We designed for our final restorations. This was going to be monolithic zirconia restoration on multi-unit abutments. And these are the designs and adjustment of occlusion. And then the milled restoration after our staining and glazing, of course, and adjusting the gingival levels and everything else. This is the passive fit that I was talking about. This is screwing in the full arch restoration in the patient's mouth. You can see how passive the screws are going in, and how we have a perfect fit for the patient, and the final restorations at the end. Of course, the facial photos with the patient's prosthetics, so that you can see the final results. At the end, I'd like to thank you all. For once in my life, I was exactly on time, and this usually doesn't happen. I'm sure Dr. Amr will always tell you that I usually take too much time in all the conferences that we are together when we give joint lectures. And let's say we're sharing a lecture together, I usually take half of his time and more of mine. So I hope that you all enjoyed, and I'm open for questions now. So
Okay.
Dr. Amr, if you have any questions, I would be more than grateful to go on with the question, with answering them.
Thank you for your amazing lecture.
Thank you so much.
Okay. Many dentists here, especially those who are starting to make full arch rehabs or implants in the aesthetic zone, we saw you use lots of guides, lots of face scans, DSD, and lots of difficult stuff.
Okay.
My question is it mandatory that you use all these tools to make implants in the aesthetic zone, or just to make things better?
It is a must. Yes, it is a must. Why? It's actually quite easy to imagine. Imagine yourself as a dental technician, okay? Because who designs your prosthetics at the end is the dental technician, not you. So imagine yourself prepping a veneer case, a simple case. It doesn't have to be implants, okay? Of course, a veneer case is much simpler than a full arch implant for an anterior zone. He's holding the model in his hand, and now he's starting to imagine what he needs to do for the case. That's the first step that he does. The first thing he does is try to adjust horizontal of the part of the model, meaning that I hold it this way, or straight. Because if he goes to a certain angulation, then it will be longer on one side than the other. So what is the reference to decide? So what if you have a case with multiple spaces? Okay, where should the midline be? He doesn't know. The only information he has is where the teeth are. So mostly what he will do is give you a midline between both centrals. Is this going to look good on your patient or not? You never know. You will only know if you have the face there. What about the rest of the spaces of the teeth? Should I give a space more for the central than the lateral, or the canine than the premolar? I still don't know because I have no information there. What about the buccal corridors? Should I close them or should I open them? He still doesn't know. What about the incisal edge? Should I make the teeth longer gingivally or incisally? I would only know if I had the lower lip there and the upper lip there while the patient was smiling. Like the first case we saw, I could never decide where my new incisal edges should be and where the new gingival margin should be. And would this look good on my patient or not, unless I had the face there. So going back to your question, Dr. Amr, you started with that I'm doing a lot of things that seem difficult. They are not difficult. They are very they seem difficult, okay? You just need to learn how to do them. We have simplified the smile design process to the utmost. It started with a very difficult process in the beginning, yes, but now it's something very simple. You have a lot of apps even that with artificial intelligence that make this even easier. The amount of records that we need to do a correct smile design used to start with 50 photos. Now we usually use 1 to 3 main photos for the smile design process. You don't need to have an intraoral scanner to do this. You can just send your model or your impression to your lab technician and he would scan it for you. There are a lot of planning centers that will do the smile design for you now, even. Do the digital wax. This is the lab work. Is it mandatory? Yes, it is. There's no way that you could give an aesthetic proposal for your patient or your restoration would look good and natural on that patient. What I call it is you would never be able to give a customized smile for that patient. When you go buy, let's say, a new car, okay, you want to customize that for your needs, right? And this is a car. But when you're giving a patient a smile, it has to be that specific smile that looks good on that patient. It would never look good on him unless it looks good on the background, which is the face. So for your teeth to look good on your lips and your face, you have to have the lips and the face as a reference so that they would blend in and would look customized for that patient. So that you can give something totally different than a lot of smiles that we see in the market right now. Totally white, flat incisal edges, and something that looks totally artificial. This is not what we were brought in the world for. This is not what our profession is about. Our profession is about giving back our patients what they lost. Our patients used to have a natural smile. We want to give them back a natural smile as much as possible, not an artificial one. And this is what many of my patients tell me. I want super white and I want them flat. I tell them, you can do that with any dentist in the world. Okay, it's the easiest thing. Any lab technician, any dentist can do this for you. But if you want a customized smile that looks good on you, that looks natural, this is what's hard. Okay? The tools to do this is easy, but it takes a learning curve to learn this and takes time and for you to really understand this and believe in the concept so that you can reach good results or better results for your patient at the end.
Okay, one more question. How accurate does the digital plan mimic the final restoration? Is it the exact same thing, or it's quite there is quite some deviation?
You mean the digital plan as the wax up?
The digital plan as a wax up and the final restoration at the end that you deliver to
How
the patient.
close are they to each other? If they, of course, it depends. If everything goes well, and if you have pre-planned everything, okay, to the extent that everything goes perfectly, then it would be a perfect match. Okay, you would be able with CAD/CAM technology to copy the wax up that you have done with all the texture that you have there, okay, to the final restorations up to 95 to 96%. Okay. Given that the soft tissue healing that you had expected and all the planning that you had done in the beginning went well, given that, of course, with full mouth rehab cases, as the cases that I've been showing you today, these are the most difficult cases that you can really get a 95 to 96% copy of the whole thing, because you have a lot of things that you are waiting to see results from: soft tissue, bone healing, a lot of other things. But when you're going for a prosthetic veneer case, this is very easy, given that you have used guides for every single step. Meaning, you can plan everything very well, but at the end, not use a surgical guide. Don't expect to give the patient the final restorations that look exactly like the mock-up or the wax-up that you showed them. You didn't use the guide. So we not only need to guide ourselves as clinicians, we need to guide our lab technicians. So this is the whole point of digital dentistry. Everyone is guided, or the lab technician is guided, the clinician is guided, and the patient is also guided by meeting his expectations with the mock-up and showing him everything before we start. But you need to go through the full protocol, use all the guides possible. A simple gingivectomy, yes, use a guide. Crown lengthening, use a guide. For a single implant, use a guide. Okay? Why not? Why not? Right? Yes, your hands could be perfect. You could be the best surgeon in the world. But I'm sorry. Use your expertise as a surgeon in the planning process, and just use the guide in the patient's mouth, right? Use your skill, surgical skill, when where the complications come in,
Exactly.
right?
Yes.
There's never a straightforward implant case.
Yes.
So the best implant treatment planners are, yes, the surgeons, but when they use it on digital softwares, and when they can put their hands away from the patient and put the guide in and use the guide, that's the best combination: expertise and skill with technology. Technology alone will be a disaster if you do not have enough knowledge, right? Because you're planning totally in the different perspectives. And skill alone without technology will never get you to the standards that the world is seeking right now and our patients are seeking right now.
Okay, I liked your last case, the 3D camera. Okay.
Yeah.
What do you expect the future of these types of cameras? The stereophotogrammetric or 3D cameras?
Yes, as any digital technology, when anything new is introduced, it's quite difficult to get around with, and especially that the prices usually at the beginning are quite high, right? Like
How
any
much?
digital technology that we've seen. Maybe later on I'll tell you.
Okay, no problem. It's not a marketing session, of course.
Yeah. But the technology is magnificent, actually. Being able to scan a full arch case in less than 15 seconds, as you saw, with that accuracy, with that much of precision, being able to finish the case with Adrian coming in just for 24 hours, his flight's already reserved, and the hotel night's already reserved, and Adrian just was coming in for one day and leaving the next day. I was like, are you sure we're going to be able to finish this case? He's like, yes, of course, we're going to be able. I was like, because I know all the problems that we have met with full arch cases, especially with the prosthetics. As I said, the surgical phase is nothing next to the difficulties that we have with the prosthetic with the full arch cases, right? The amount of verifications that we need to do And even after that, the amount of difficulties that we have with the final restorations, being able to do this in 1 day with that much of accuracy and precision and passive fit was amazing to me. And this is the future, actually. And this is what we're going to, and by time, this technology is going to be very cheap. I'm not saying that it's too expensive. It is worth the amount of time you're saving and the quality that you're giving your patient right now, right? But by time, this is what I see as the future. This type of technology is going to be in all our intraoral scanners.
Yes.
And as you know, Dr. Amr, any technology that we have, digital technology that comes out in the beginning is very expensive. And we are usually the type of people, I know you've done this many times. You bought this with thousands of euros, and after 1 year, everyone has it in the market, and it's for peanuts. But the whole point is
to take the lead.
Yes, exactly. That's something that's very important to us as lecturers, and as people that are implementing digital dentistry, of course.
Okay, one final question. I want a take-home message to young dentists who are starting to work in the aesthetic zone. What do you advise them?
As young dentists, you are the future. Why? Because you are more familiar with technology than us. You were brought into the world of technology, actually. Computers are very simple, or mobile devices are very simple for you. Softwares are very simple for you. So you are the future of digital dentistry. This is what I tell all young dentists. The technology is there. We started at a time where not all the digital technology was there. It was much difficult for us. Everything was very expensive. Now everything is much cheaper. The amount of intraoral scanners that were sold for the past 2 to 3 years was amazing and enormous. Why? Because the prices went down. That's easy. There are a lot of free softwares that you can use now. What I want to get to you at the end, you need basic knowledge in the beginning. This is very important. You need to learn, especially when let's say we're talking about implantology. You need to learn basic implantology. You need to know how to do the analog way first. Then, only then, go into the digital. Get the skill and expertise you need from analog, and then use this expertise with digital technology. This is the perfect combination. But analog only alone or digital alone is never enough. You need both together. And the number one issue that will make you a successful dentist is treatment planning. Treatment plan your cases. Take as much time as you need to treatment plan the case. Take as much information as you need so that you can get the right treatment plan for your cases. And this will be your best ally for your cases at the end. Your worst nightmare or your biggest enemy, to me, at the end, by time you will understand this, is function and occlusion. And this is where most of your failures will come in. So when time comes, you will come to the point where you want to understand occlusion more. Don't take this at a very late stage, because you will learn this by time with the failures that you see with your cases. Don't wait for the failures. Try to understand occlusion more. The easiest way to understand occlusion is to simplify the process. Our biggest problem with occlusion is we feel that it's too big and it's too much information. No, it's not. It's very simple as any information that we have or any branch in dentistry. Just try to simplify it out so that you can understand it more, and try to find a workflow that suits you and gives you better results.
Thank you very much, Dr. Mahmoud, and we hope to have one more lecture about digital occlusion. I know it's one of your favorite topics.
Sure. Yes.
Okay. Not mine, okay. But it's a very important topic. We thank you very much, and have a nice day, everyone. And still, you must stay safe. Thank you, everyone. Thank you, Dr. Mahmoud.
Thank you all. Goodbye, and thank you so much for your time.
Goodbye.